But what's in that autobiographical memory bank has been massaged by you to make who you are, perhaps, more comfortable or less distressing. Think of the implications of that seemingly trivial idea with regard to helping people become happier. One might suggest then that a given memory that ruminates in the individual, you understand rumination as a process by which we revisit memories, but often rumination is reserved for the idea that we didn't intend to revisit these memories. That is, these memories and the images intrude upon our stream of consciousness. Are these terms sounding familiar to you from the last class? They intrude upon your stream of consciousness, and they're annoying at the very least, and devastating at the very worst. That is, they can stop you in your tracks, and you become incapacitated at that moment in time, depending on what you were doing, and you feed directly into the blah, blah, blah criterion in which this aspect of your life is causing difficulties for you in terms of your ability to function on a day-to-day basis at home, at work, or at school. Now, with that having been said then, wouldn't it be interesting if we could take that memory that is so intrusive and work on it in therapy? And what do? We have to maybe revisit it, reinterpret what might have happened, reinterpret the value, reinterpret the intentions of the people who may have caused difficulty for you at that time. Put it another way, we may bring that memory out onto the table, massage it, put it back in a much less threatening state. And if it's in a much less threatening state, it is less likely to intrude upon your consciousness in this form of mental activity that we call ruminations. And ruminations, as you will learn soon, are often seen at the core of what we call depression. It is a thing that affects our mood, that disturbs our mood, that suppresses our mood, and contributes to the process of our not being able to move on, putting in the rearview mirror those experiences that may cause difficulties, putting them in the rearview mirror and driving on with the rest of your life. And the farther you drive, the more distant, the less meaningful that memory becomes. Does all this make sense to you? I mean, there's no rocket science. I told you that. There's no rocket science in this course. Yet, everything I have just said to you is very important when we understand the process of dissociation. Because what are we saying about dissociation? We're saying at any given moment in time, as you are experiencing reality, and as you are about to take that reality, extract pieces of it, hold it, and store it, that process is to a large extent under your control and may allow you to put into long-term memory those pieces of those experiences that are indeed less threatening or reinterpreted to make your life more comfortable. And indeed, a lot of people argue that psychotherapy is indeed restructuring the cognitions around the memories of stressful events. Frequently, psychotherapists will be visiting with a patient a memory from early childhood. That may not be sexual abuse. It may be simply formative in terms of how they may feel good, or in case of needing psychotherapy, bad about themselves. And psychotherapy then would strive to reconstruct the imagery, the cognitive state, and ultimately the nature of the autobiographical memory that is put back into its storage and later retrieved, hopefully in a different form. So at the core of what we're talking about here is not only the etiology of how stress creates psychopathological states later in life, or even immediately, but also the process by which two people interact in a psychotherapeutic relationship to help that person who is the recipient of the treatment reconstruct the memory of their lives in ways that makes their current life more manageable, more livable. And by definition, because what's the bottom line here? Bottom line, what do psychologists do? What do mental health professionals do for the individual? And what's the goal? What's the overarching goal, as we sometimes call these things? Is it to reduce the stress and thereby increase the capacity for what people say about whether or not they are, what's the word I'm looking for?
Functioning.
Happy. Right? And you'll find later on that most mental health professionals will assume a posture around these issues in which they say, that is the goal. I want to help you get more out of life by which you will evaluate your life as being more happy than sad or than tense. My job is not, by the way, as you'll see in a very controversial case I'll share with you a little later in the course. Mental health professional's job is not to get to heaven. That's somebody else's job. Sometimes you'll see those two things conflicting in terms of what goal is getting you better position in the next life versus what goal is going to get you in a better position in this life to derive the most glory or happiness or satisfaction. Okay. So I've gone over this. I've gone over this fundamental memory stuff. It's pretty easy. The three-stage memory process, and you get it, right? It's sensory, it's put into short-term. Short-term is the sometimes the short-term memory is called the workshop of consciousness. It's kind of like, this is what's going on. Okay, what am I going to do with it? All right, I got to find a way to store this. Sometimes that happens easily, depending on the intensity of the experience, or the importance of the experience, or the thrill of the experience, or the stress of the experience. And sometimes you have to work on it. To get question number 36 correct on Prince's test. Sometimes that part of that long-term memory is more difficult because it lacks the same sort of input and impact. So, okay. We've already gone over this piece, I believe. Correct me if I'm wrong. This is a regurgitation of what I've been saying since I started this piece. You must understand, and I think, and I hope I'm actually addressing something that is your reality, and that is you think your memory is simply retrieving the event as you remember it, and that's what happened. I hope now you understand that when you retrieve the memory of that event, it may not be what happened. It may resemble what happened. Does this make sense to you? It may have many features of what actually happened, but actually it's highly unlikely that you remember it exactly as it happened. And now all of the factors that go into mediating how that memory is stored are numerous, but almost always, not in a bad way, almost always self-serving. So, two areas where this can go wrong, if you will, with regard to the absolute representation of reality. One, storing it. Two, retrieving it. You now know that when you retrieve that memory, the more complexity, the more vulnerability to error, because it is not pulling an electrical event off of the synapse. It is drawing off of and integrating several parts of the brain that must reactivate in order for that memory to be retrieved. Once retrieved, there is no doubt that it has lost some of its accuracy with regard to reality. Add to that, now we're getting right to, what's her name, video. In as much as each retrieval is a new reconstruction, when you're listening to someone help you reconstruct that memory, your memory of the event will be altered by the way that person helped you reconstruct the memory. Now, I may have addressed this earlier in the course very briefly, and I said I would return to it. But remember, I should have used that in that particular term. But remember this, that if we took everybody in this room, remember the study that I referred to very briefly? And we put you into a study that's usually done in a memory laboratory, and we described for you the event in the 5th year of your life in which you were lost at the Plaza Mall, or whatever mall you lived near. And we actually constructed that event for you to help you remember that event. And we knew from having talked to your parents that it never happened. Half of you would go out of that room having reported to us that indeed it did happen, and you will help embellish the details of that memory. Half of you, put another way, just using the correct words in that experimental situation, we can create what? Repressed memory? Obviously not repressed memory because it never happened. Exactly. False. We can create a false memory that has now become a part of your reality. And if you don't believe this, understand that in that experimental situation, we can enhance the number of people that we pull into this by showing them pictures of the mall to help them remember the details of their having been lost. Now, mind you, we're talking about people who've never been lost in the mall, and they are walking out of that experiment believing that they were, and that now has been a recovered memory in their mind until they are told, debriefed, that we deceived them. They are debriefed to the extent that now we say, sorry, we hope we didn't do any harm, you actually were not lost in the mall, blah, 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 and everything is fine. Now, they may still go out, just like this young lady did here. Does she not now know that her father never abused her in any way? Yeah, she knows that. You saw in that video a traumatized individual who could satisfy the criteria for PTSD on the basis of false memories that were created in therapy. I used to think psychologists weren't dangerous people. I used to think the only people who are dangerous are people who use scalpels and drugs. Psychologists can be very dangerous people when they don't pay attention to the fact that the person sitting in the chair who is requesting help is, by definition, the moment they walk in the door, extraordinarily vulnerable. And this is one way in which that vulnerability can eventuate in a very bad situation, as you saw, the worst case situation in that video. So, I hope I didn't burst your bubble with this idea. I remember, I'll give you a memory that I have. You tell me if I have it. And because I think you have these kinds of memories too. I remember my brother's friend coming by the front of the house on the way to kindergarten, walking to kindergarten. My brother's 2.5 years older than I am. He was in kindergarten at age 5. I remember the image. I can picture this as clearly as if it happened yesterday. That puts me somewhere around 3 or a little less. You talk to a memory expert, what are they going to tell me?
No.
Very unlikely that that's a real memory. So then why do I remember this? It could be that my parents helped me with that as we reconstructed things about the way they happened at that time in my life. So, that second or third birthday that you remember as clearly as if it happened yesterday may very well have been massaged by the people around you talking about that particular incident and a tick that took on a life of its own within your memory banks. There is a woman whose name I always forget, and she is the dean of false memory research. I'll think of it before the end of the class, but her story is this. She was traumatized by the memory of her mother, finding her mother in a pool face down, having drowned. At a young age, I forget if it was 7 or 8, might have been even a year or so older. Horribly traumatic memory for her. At a point in time, I believe very close to adulthood, if not within adulthood, Elizabeth is her first name. Loftus, something like that. Look her up. She's got a website about false memory if this interests you at all. And the story is this. She got together with relatives and her aunt during this little get-together heard her say something about finding her mother and corrected her and said, you weren't even there. In fact, you were told about what happened. You were not the one who found her face down in the pool. So you see, that got Loftus, Elizabeth Loftus, that got her started on the whole business. How could this be? Her aunt absolutely convinced her it was impossible for her to have found her mother face down in the pool. And yet, for her, for many years, it's a very distinct and obviously very traumatic memory. So can you see how it would have happened? She listened very carefully in a very confused sort of a way, as we are when we are younger, as children, when those memory processes are very primitive. Somehow she got to the point of being traumatized by the story and then believing she was a part of the story, at least with regard to the experience from Elizabeth she experienced. Elizabeth Loftus is her name. She's literally the leading expert on false memory if you're interested in that whole area. Okay, so that's the third bullet here. The distortions in memory obviously occur, as we talk about it, with people who may have experienced the same event, but obviously experiences differently. Now, please remember, I'm asking you to revisit this again. False memory is something studied in the psychological laboratory. If you're dealing with a psychodynamically oriented psychotherapist, by which this means a psychotherapist heavily influenced by psychoanalytic Freudian and neo-Freudian theory, this will be referred to as repressed memory. And you will be convinced by that individual, not all, but several, that indeed a very complex event can be completely repressed and not any aspect of it available to consciousness ever. This is a very controversial issue. You really can't prove whether or not it's true or not true, but suffice it to say that dissociation is a very real process that can alter significantly the experience of a given event, and it may appear that what has been experienced has been totally repressed. But when, again, this is the test question waiting to happen. If I get any other, I've been really bad lately about forgetting to do that. But the test question waiting to happen is, and this is the second time I'm saying this, if there is zero, absolutely no recollection of any part of the events, and it emerges in psychotherapy, my money, and I will bet my money on it, that it is a false memory created in psychotherapy. If, on the other hand, there are actual pieces of it that the person is already convinced happened, but that they've repressed aspects of it, like I saw in one patient, a headache patient that I was seeing, who claims to have been and was indeed sexually abused by her stepbrother. And in therapy, here's the second time and last time that I did not take control of therapy. You remember the other time, the agoraphobia case that I presented and went to the house of the agoraphobic against my better judgment. Against my better judgment because I knew this patient very well. And it was kind of like unfinished business that she wanted to finish. For me, it was not even on the table. But she said, those memories are very unclear. I would like to revisit them, understand more completely what happened, and then, and she would always hear from me, put it in her rearview mirror and drive on, leaving it where she left. Long story short, I just finished training in hypnosis at the time, and I had incorporated hypnosis into my practice, and we did age regression, and we proceeded to uncover significant details of the repressed elements of memory of an event that we knew actually occurred. The next day, she called in an extreme state of major depression. It turned out, long story short, the revisiting of those memories was extraordinarily a bad idea. False memory research in that particular day had simply not hit the press. I was operating as all therapists did in those days, using hypnosis as a window to the unconscious and helping her do what it is that she thought would be a good idea. End of story. It was a very bad idea. And I saw her daily for 2 weeks to help her through that major depressive episode. So, again, I return you to the idea that psychology can indeed be very dangerous when there are levels of incompetence without regard to the data that are out there that should be directing what it is that we do and we don't do. My excuse, of course, in that particular instance was that I did not have the benefit of research that today is well known, and now therapists, if they're informed, are far more careful. Okay. So you know repression then is a psychoanalytic version of false memory. I've made these points now, so let's move on to the dissociative disorder. Extremely important for all that I've had to say about memory, about dissociation, about the stages of memory, and about its delicacy. At the very least, I hope everyone in the room now gets the impression that memory is a pleasant state, as I introduced it. It is indeed quite delicate. Now, there's dissociative amnesia, the most common and least debilitating of the dissociative disorders. Depersonalization disorder, the textbook will have you believe that in fact that is a chronic and often very debilitating disorder. I'm going to describe a textbook case for you that ended up in my office that in fact was a quite functional young lady. And You'll get a different impression of depersonalization disorder from my account than you will from the textbook. Dissociative fugue, very controversial, but nonetheless interesting and real phenomenon that has occurred in the lives of many individuals. We will not cover dissociative trance disorder, but we will indeed cover dissociative identity disorder, and I'm going to make the time for you to see a video of a patient where, you remember I told you at some point you're going to have to make your first differential diagnosis. And I want you to tell me the patient that you see. This rather lengthy video, it could take most of the hour to show this to you, but I think it's that well done. You're going to make the determination of whether or not this person is a dissociative identity disorder, formerly known as you see, multiple personality disorder, the Sybil variety, or a sociopath, psychopath, or as you will come to know it before the end of the segment, is he rather an antisocial personality disorder, which is the diagnostic entity that has replaced sociopath and psychopath. And then there are, of course, like all other disorder groups, there are the NOS variety of these things. When they don't fit, we still have a place for them. Dissociative disorder is not otherwise specified. A couple things I still haven't taken out of these next couple slides. I'll just make the point as we go along. What is dissociative amnesia? If you get it, in terms of what I said about association, it should be pretty clear to you that there can indeed be holes in our memory of experiences. When those holes are large enough to rule out normal memory failure. Normal memory failure typically refers to a very small piece of an event or a very small piece of information that eludes us or escapes our ability to retrieve it. Amnesia, as you can see from bullet 2, must have sufficiently extensive experience involved that cannot be attributed to ordinary forgetting. Normally, these disturbances of memory that we call dissociative amnesia, the old term, by the way, if you get, and this is important for you to see this, I appreciate the issue here, the old term is psychogenic amnesia. It's now dissociative amnesia. Psychogenic didn't tell us anything other than the fact that there were psychological factors accounting for the inability to recall a significant, extensive amount of experience. Dissociative was the replacement term because it identifies the process by which the information was not remembered or cannot be remembered. The person is likely to have dissociated, not allowed the experience at the time that the event occurred to penetrate consciousness thoroughly in such a way that all of it could be retrieved as a memory later. And if all of what I've said to you about memory now, or up till now, made sense, then this should make sense to you as well as a diagnostic entity. So this is just a very simple situation in which we cannot recall significant pieces of an experience that is likely to have involved some sort of trauma. Anyone who's ever been in a major automobile accident, I'm sure that applies to several people in this room, can tell you the trauma of that. In the absence of head trauma, because of course if the person banged their head against the side window or something else, we have a whole different kind of amnesia that needs to be ruled out. If, on the other hand, the experience of the accident itself was psychologically traumatic, there is likely to have been significant pieces of it that are not easily retrieved by the individual as those experiences are tried, as one tries to recall those experiences. I hope you see the utility of dissociation. In these instances, it's better if we had every traumatic event in our life immediately available to consciousness we would be dysfunctional from the beginning of our day to its end. Does this make sense to you, especially those of us who have experienced a lot of trauma? So not only does dissociation work well, but it in fact feeds our ability to function effectively. When then does it become a disorder? It becomes a disorder, you know exactly where this is going. When it affects our ability to function on a day-to-day basis at home, at work, or at school. It's always where we end up in this disorder business. Okay? All right. Inability to recall important personal information, usually related to some experience. The information is sufficiently extensive that cannot be attributed to ordinary forgetfulness. There's usually trauma, or at the very least, some stressful experience. And by the way, I'm distinguishing, as I hope you got in the previous segment on the anxiety disorders, stress is stress, and trauma is trauma. Okay, here's the test question for you. Trauma is to panic as stress is to anxiety. How's that? Does that make sense? Trauma is the worst form of stress. Panic is the worst form of anxiety. So, in this instance, it does not have to be traumatic, but would certainly, you would expect it to be a stressful situation where someone starts dissociating off of the way experience is, the way life is experienced, and the way that it is ultimately going to be remembered. Okay. Oh, there's that. There it is right there, right? Is there any microphone expert in here that I would give my left arm to after several semesters in this room to fix this thing? I think it's consistent. But, all right, so forget, if you have these notes, just cross number 1 out. Number 2, number 3, number 4 bullets here are more important. Number 1, actually number 2 on this slide. The more, higher, let me put it this way. We have tests of hypnotic susceptibility, which means nothing more than how susceptible you are to suggestion. How susceptible you are to the idea that you were lost in the mall and in fact you weren't. Everyone has a different level of susceptibility to suggestion that may even vary at the time, at the moment, from moment to moment, okay? Based on changes in circumstances in terms of how you feel. Those of you who score high in this vulnerability to suggestion, what we call hypnotic susceptibility, are more likely to have revealed a dissociative disorder. And as such, more likely to have reported a psychogenic amnestic experience, a dissociative amnestic experience. Or, put another way, more likely to have been diagnosable with dissociative amnesia. Notice I didn't say diagnosed with, because this is indeed one of those areas where it is not likely to necessarily have created the inability to function on a day-to-day basis. But yet you may well have satisfied the other criteria for, look at those criteria, extensive information, can't rule it out by forgetfulness, stress was encountered, etc. This is a relatively innocuous dissociative disorder, which usually resolves with time. Now, when on the other hand, it does have an impact on the ability to function on a day-to-day basis, clearly the one that's probably then will have been diagnosed with the disorder and therefore treated for it. Some people think that dissociative amnesia is on the increase in the U.S. When they do the epidemiological statistics, it appears the prevalence is rising. We don't know if it's rising or people are just more, and I think this is the answer, people are just more amenable to seeking help from mental health and medical professionals when things happen. we've softened our resistance. We've softened our defensiveness as a society about sharing these kinds of difficulties with an authoritative professional. And when you see it in the VA population, very often it is connected to what do you expect? Where would trauma be produced in the VA population? Veterans Administration population I'm talking about? Obviously in the medical branch. In which case, the dissociative amnestic experiences are often connected to PTSD as it presents itself in the clinic. Rule out malingering. Hey, I changed the top line. I used to have the Richard Nixon syndrome, and I recognize that nobody in this room is ever going to remember what Richard Nixon was doing back in the day. Although I heard recently as yesterday that he was doing something even nastier, like communicating with Vietnam about sustaining the war so that he could get reelected. Have you heard this? It was out the came out yesterday. Probably evil. Anyhow, today. So who knows Jody or how she pronounced that artist? When you follow this, you watch headline news, you can't help but follow it. This lady, how many people have heard of this lady? Okay, yeah, because she's on the Yahoo News and everything else too, right? So she stabbed this guy, was it her husband or boyfriend? Stabbed this guy 30 times. Did she shoot him too? Yeah, she shot him too. Needless to say, he's dead. And she's on trial for murder. And the interesting thing is, she's really very bright, very articulate, and as you see her testifying, she has a terrific account for just about everything, except when she murdered. Is it possible that she has dissociative amnesia with respect to those specific details? Yes. What is your professor going to bet? The professor is going to bet that this is malingering. And let's just visit that. We'll revisit it again in the somatoform section of this. What is malingering? Malingering is the occurrence of a symptom whose presence results in a payoff for the individual. It is voluntarily manufactured, and the outcome is either money or no jail. Or there are some other potential outcomes as well. But if, as I am led to believe, there are people feigning symptoms to achieve Social Security disability, or if there is an instance in which a parent is insisting that their child stay on ADHD medication, because if they go off the medication, the Social Security disability goes away, and that's malingering. In one case, it's malingering directly, and the other case is malingering by proxy. And we'll visit that in the somatoform disorders. But that to be, you're going to have to differentially diagnose that from factitious disorder. Factitious disorder is the appearance of symptoms whose only value is to achieve the care, understanding, and compassion of the person whose attention, usually a medical or mental health professional, whose attention is needed by the individual for whatever reason. So they're not really going home with a paycheck. They're going home feeling loved, cared for, etc. That's factitious disorder. Malingering, and by the way, they have no idea. They're not voluntarily producing these symptoms to get the compassion of the helping professional. It's just connected that way, and they don't even realize that it's connected that way. In malingering, the person is absolutely aware that what they are unable to recall in this particular case, malingering can occur with any symptom. In the case of amnesia, it is arguing, claiming, if you will, as she is doing, that she doesn't remember any of the details of that which is ultimately going to send her to jail. She's not made a very convincing case for her jury, unless those of you who are watching this feel differently. She's not a very convincing person, and a lot of it has to do with the emotional component, or I should say the lack thereof, of an emotional component that we're seeing in the corporate text. She switches story, yes, she's not. Oh, now this can happen. We have to describe a situation 5 times. It's going to be identical all 5 times. It won't be. But in her case, it's much more profound than that. You had a question, too. Yeah. What's the difference between the factual, when we talk about the factual and the non-factual? That's a very good question. We're going to return to that in the somatoform disorders. But I was describing to you when a parent is doing that for a child, that's one child. Yeah, there's also by proxy, that's correct. Yeah, I'm sorry, I didn't finish that. When a parent is doing it for a child, we revisit that. When a parent is doing that for a child, in the case that I described to you, that is one child is by proxy. When someone is, in fact, doing this for themselves, it's factitious disorder. If the person is not doing this intentionally in some sort of a way that they don't understand the connection of the compassion that they're trying to get, then indeed it is factitious disorder. So Munchausen is factitious disorder. It is by proxy when a parent is doing it on behalf of the child. We'll revisit that. It's a very important question. We'll revisit that during the semester. All right, let's move